Very good morning to all of you. First of all, I would like to thanks Dr. Honava sir for giving me the opportunity. So without wasting much more time, I will just start my talk. So learning is a constant evolutionary process. That's why we are here from couching to the chopping, and sharing is the knowledge, the best way of learning. So I will start my session with some of the interesting cases we present to our cornea clinic. So all those things, the new nomenclature for all of you, so for the PG students, what exactly these conditions and why the patients are not improving, and when should I refer this patient? So to know these things, the next 15 minutes I will discuss the ocular surface. This is a nomenclature new to all of you. The corneal staining and the corneal diagram. I have no financial interest. So I will highlight following the points. What is ocular surface? As per the American Academy guidelines, the surface of the eye is an extraordinary and the vital component of the vision. The smooth, wet surface of the cornea is the major refractive surface of the visual system, which along with the corneal transparency enable the light to proceed through the lens and onto the retina for photoreceptor activation. Presence of the smooth, wet refractive ocular surface required for vision comes and however at a cost. Unlike all other wet surface epithelial of the body, the ocular surface is directly exposed to the outside world where it is specifically subject to desiccation, injury and pathogens. As a consequence, numerous protective mechanisms are provided by the ocular surface system to ensure these things. It is not that much very big, tough like that definition. So I will make it very simple what exactly the ocular surface. So the component of the four component is there. It comprises of the lids and the nexial and the stability or film, the corneal epithelium and the conjunctival epithelium, neurosensation and the vascular and the immune system and the endocrine. So ocular surface system, it firstly depends on the provide the protection and the maintain the smooth refractive surface of the cornea. Secondly, all the epithelial cells at the ocular surface are continuous with no breakage in between region and all are derived from the surface ectoderm. Thirdly, all the regions of the ocular surface epithelial proceed component for the refractive tear film and the function of the various region of the continuous epithelia and the eyelids blinks are integrated by the nervous, endocrine, circulatory and immune system of the eye and are supported by the connective tissue with its resident cells and the blood vessels. So if it makes very simple things, what we have discussed the definition, the ocular surface components are the functional units of the blink reflex, the conjunctiva, the cornea and the limbus, the tear film and the Meibomian glands. So recent diagnostic modalities, when should you know what is the, we have the infrastructure because the whole ocular surface is maintained well by the covered by the your tear film. So normal tear film we have the lipid layer, aqueous layer, mucin layer and the epithelial. So normal evaporation rate and the normal blink reflex we should have checked whenever we are dealing with the ocular surface disease. Now what we have the advanced one. So first we start with the dry eye questionnaire. Whenever you have to when the patient come to us, we are suspecting the patient have this is the form a little bit of hazy for the entire whole thing. I want to just put in there, but you have to some basic question you ask the patient. First of all, patient whatever the patient the exposure any screen time is there or not, what any hormonal disorder is there or not, patient whatever any systemic disorder, any medication. Specifically, whenever we deal with the suspected OSD patient, we ask the patient whether any patient having the any history of the dryness in the mouth and any small hand joint pain to rule out the collagen vascular diseases. Now come to the point to the non-invasive breakup time. It's mainly for the lipid layer, and we are not instilling the any your Sharma steps. Now the fluorescent one, we have the very important diagnostic. This is very readily available. I think every postgraduate institution. So in by fluorescent, we can do the qualitative, some of the quantitative tests. The quantitative test is that Sharma test. We are routinely all of us do, and the corneal staining, tear meniscus height, and tear breakup time. This means again, when you were suspecting the patient having the your conjunctival devitalization or dry eye changes is there, Lisminic is one of the readily available staining system for us. The Sharma test usually quantitative value of the tear film when it is usually more than 10 it's normal. When it is been between the 6 to 10 mm it is moderate to dry, and when it is less than 6 the severe is suspected. Usually we do prefer Sharma 1 without any anesthesia doing. That's we are doing the complaint combine both the reflex tearing and the basal tearing. When you have installed that paracrine drop, then we are on another anesthesia drop. We are usually detecting the only the we are cut short the reflex tearing on the basic the tear secretion we are assessing. Now the osmolarity, this is the gadget, so we are available to know the whenever the patient whether the tear whether it is hyperosmolar or normosmolar. If the tear film is hyperosmolar, that is actually if the osmolarity higher inside, that's actually it is not called the bad tear, and the it is usually some sorts of the inflammatory react. I mean the component is there. So these are the usually the schematic diagram when you how to proceed that for your dry eye patient OSD patient. Same thing you have to ask the questionnaire is how severe the patient discomfort, how long the pure symptoms, whatever we are talking about, the lust and how and was there any triggering events is there or not in your vision affected those the questionnaires you have to ask the patient. Once you have the questionnaires, then we have to proceed for the diagnostic test like non-invasive one, the invasive one, the breakup time, osmolarity, and then we do the staining thing. The last we do the staining part. The how to important ocular imaging at the usually we already have discussed these things: diagnostic, etiology, etiological argument, severity, and follow up of the treatment. So there the tear film breakup time. It give you the qualitative test of the tear film. All of us know how to do the tear film breakup time. This simply the way of installation that is very available the your fluorescence strip. We just install the fluorescent tip and ask the patient just blink and just open at the gauge or blue filter, and where you get the you randomly the first spot is appear, that is first you have to count the things, and that is your simple the tear frame breakup time. Usually it is TVT is more than 10. If it is less than 10, you suspect the patient have the trauma of the dry eye component is there. If it is less than 6, that's the patient have the severe dry eye is there. And tear film stability, that non-invasive tear film, whenever you have the your topography system, we can use the without installation of the your any fluorescent dye, we can use the non-invasive tear film breakup time. So now what are the spectrum of the ocular surface disease? The main causes are age, whenever the suspected patient more than 50 years, the climate when the patients are having working in a very your hot humid climate, and some of the genetic predisposition, gender is usually female patient of the postmenopausal work environment. So whenever you have long your screen time and systemic disease and medications, whenever the patient have the long-term system medications that can causes the ocular surface disorder or OSD. Secondary OSD as Sjogren's syndrome, rheumatoid arthritis, and lupus, and reactive arthritis, thyroid dysfunction, diabetes, rosacea, and medication. And whenever the patient having some of times we have noticed the patient having the post-refractive surgery and the chronic use of the contact lens users. So now we are just dealing with how the clinically presentation. This is the actually patient having the SJS patient. You can see the keratinization of the surface. This one of severe dry eye patient. We have the T minus near 0. This is the patient of the, we can see, can you even elaborate what is this? This is the shortening of the foundation shortening. This is the OCP, ocular secretarial pemphigoid. This is Sjogren's one. This is the severe keratinization ocular surface that is due to one of the sequelae of the SJS patient, and this is the very classic case of the one of the medicamentosa for the long time using of the acyclovir or the potential medications. So whenever you are dealing with the ocular surface disorder OSD, so what is the prerequisite for the whenever specifically we are concerned of the any intraocular surgery. So whenever you are dealing with the OSD patient, the following things should be you keep in mind before going into surgery in the OS suspected OSD patient. Nose, there should be no surface inflammation, the eye should be moist, correct tear film instability, IOP should be controlled, sound positive segment, appropriate IOL power calculation. Specifically, the Chitra madam was telling, if you have the dealing with the dry eye patient, you do the your K1, K2 reading, you may be landed up with the erroneous result. So you have to correct your this tear film instability, then do the refractive error, and the rational surgical plan with minimal tissue handling, and always team approach is always better. Whenever you think you need some of the assistance from your other subspecialty colleague, specifically ocular surface or the oculoplastic colleague, take their help for any patient having the your suspecting of the lag of ophthalmos or any other lid abnormalities are there. So management parts is that I am not going in details of the management. Whenever dealing with your OSD patient, when all the prerequisites are fulfilled, then there should be the treatment modality or address should be to minimize the evaporative tear loss, stabilize the tear film, protect the ocular surface, repair the ocular surface damage, increase the lubrication, enhance the glandular secretion, and the cure the inflammation. One thing I would like to add that these are the schematic one. Whenever you are suspecting that the ocular inflammation is a don't give any inside job. It's strictly contraindicated. Whenever, if you think there's ocular surface inflammation is there, you can use the loteprednol, low dose of steroid with close monitoring. Strictly no for the any inside the drops. Now come to move into the next one, the corneal staining and the color coding. So what are the dyes are used in ophthalmology for a variety of the diagnostic procedure and ocular procedure and the surgeries. In clinical practice, the use of individually wrapped sterile dye impedant prepared strip is the preferred staining technique. We usually prefer because it's a very your hygiene and the sterility is more better whenever using the strip one as compared to the solution one. So most commonly we are using in our day-to-day practice the fluorescent one. The fluorescent strip which contains the 0.6 milligram or to 1 milligram of the dye, it is, and solution having the 1 to 2% solution available in the bottle form. So usually all of us know the fluorescent have a specific property. They have the property, they absorb the light of the lower strength and they emit the light in the higher strength. So that's why you have to see whether you are blue filter. So what are the uses? The diagnostic uses that TVUT, standard grading of the corneal and the conjunctival staining, tear meniscus height, and whenever we are suspecting the epithelial defect or corneal ulcer is there, abrasion, we can do it. And for the diagnostic purpose, we apply tonometry and the schedule test when we was performing, we were suspecting the patient having the any perforation is there, and how is the contact lens fitting is there. So these are the some of the clinical, we have some of the on clinic practice. So anyone can elaborate what is this fluorescence staining? Any PG? This is a dendritic one. This is the patient having the diffuse SPKP is there. This is this patient is using long time for ganciclovir by himself for the almost one more than 2 months. So landed up with the medicamentosa. This is the contact lens fitting. This one is the shield also. This is actually the picture is not that much very perfect, but whenever you have some getting the some scratch mark over the cornea, then you have to invert the lid and rule out any impending foreign body. Specifically, the you have the CP hairs is there or not. This is the your SPKs is there. Patient having the adenovir keratoconjunctivitis, but patient was treated by ganciclovir. Same thing, the medicament also is there. And this one, any can elaborate. This is a lag ophthalmos is there, and the patient having that diffuse your staining pattern is present. So advantage is that ready to use the ophthalmic strips to impregnated dye, no auricular irritation, concentration up to the concentration 3%, and no ocular toxicity. And the drawback is that more difficult to detect the fluorescent staining of the conjunctiva because of proper poor scleral contact and allergy. Sometimes the patient is allergic to the fluorescent. Now we have the lissamine green, which is available as a 1%, 2%, 3% solution, and very specifically we are using the lissamine green whenever we are suspecting the patient having the conjunctival or surface disorder. It's a vessel synthetically derived and acidic, highly affinity for staining dead or degenerated cells, and usually it is used, we are using lissamine green. We see by the red free right preferred dye for the staining for the bulbar conjunctiva. And the keratoconjunctival advantage is that the dry strip causes no ocular discomfort as compared to the rose bengal stain. When it comes to the liquid formation, lissamine green is preferred over the rose bengal stain, better visibility, less degree of the ocular toxicity. So I'm just going to the some of the ocular disorder stained by the lissamine greens. This is a patient with severe conjunctivitis, but conjunctival ulcer is there. We can see this. Take the lissamine green staining. This is the patient with lag ophthalmos. Now move to the. I just have to take 1 or 2 minutes only. Rose bengal stain. The rose bengal stain, the concentration available is it 1.3 milligram dye impending strips. Profile the properties of the dyes. Halide derivatives of the fluorescein, stain dead and the vital cells, including the mucous strands. The stain taken out by the, and specifically we are using this rose bengal stain whenever suspect usually the vital cells, and whenever suspect the filaments, and usually even sometimes it is well delineated the your OSS when you are suspecting the OSS, and it should, and usually we see by the red free light. So this is the, you can see this is the severe keratoconjunctivitis or dry eye, the filaments staining with that. This suspected OSS and the patient having that staining pattern. You can see there's a tumor cells, adenomyoplastics taking the rose bengal stain, and this is the one of the dendrites which make we zoom the picture and it's showing this delineated by the rose bengal stain. So surface staining pattern can be, we have to, this is the one of the guidelines for International American Academy, but we have the divide the cornea into 5 zones, the central the optical, the visual axis zone, and then followed by the superior, then the nasal, then temporal, and the inferior. So cornea is divided, corneal part is divided into 5 part, and the conjunctival part is divided in the 6 part, the nasal part, and the superior inferior, and then temporal part, superior inferior, and the extreme temporal part. And the grading are zero grading whenever there is no staining. Grade 2 there is a confluences grading. Grade 3 and grade 4 is the severe staining is there. These are the some of the on-time pictures. So I'm just concluding my talk by the color coding of this thing. This is very important picture for all of you. Whenever you do any cornea cases, get any cornea cases, you have to keep in mind that it should be the schematic, the slit picture should be there whenever you're drawing these things, because and it is not the your mirror image of the other things, because whenever irrespective of the OD and OS, whatever the slit picture is there, that thing should be correspond. It is the same thing as your right. It should be your left-handed sides move. That's slit one. So I'm just moving with color code is there. So I'm corresponding whenever there is a epithelial edema is there, it should be blue color dots is correspond to the epithelial one. Whenever DM folds, there are the blue lines. Whenever stromal edema, blue color zone is there, and epithelial bully like this picture.
Dr. Sarkar?
Yeah,
Can
I'm
you
just
explain?
concluding within just happened. This is my last slide. And this is the actually whenever the epithelial defect is there, it is green color. Whenever your filaments is green. Whenever the capes is the brown color, pigmentation brown color, and the aspects is the green color. These are the scar which is denoted by the black color. And whenever you have the BCL or contactless in your that is these cases, that has to be denoted by the black irregular dotted line. And whenever you have the ulcer, it should be your yellow color, and overlying epithelium is the green color. Hypopen should be yellow color, and this is the vascularization when the deep vascular straight and with the superficial is wavy pattern. So my take cleaning messages are corneal diagram and the color coding are the key to basic learning and the proper documentation. Fluorescent stain are very basic dye with immense helpful for deal with the diagnostic dilemma. Your Rosenberg stain helpful for conjunctival pathology and specifically the OSSN. Understanding of the ocular surface is must and its specific component. Eye should be moist and surface should be quiet before any intraocular surgery, specifically planned for the IOL when the patient having the suspected OST. Management should be in the molecular and the cellular level, and need to stage reconstruction when you are planning for the ocular surface reconstruction, and dedicated team approach and patient care is challenging in this very much rewarding. Thank you very much. Thanks for your patient sharing. I really thankful to my mentors of Chennai, Dr. Prema and Dr. Geeta for giving me the hands-on training for the ocular surface. Thank you very much.
Thank you, Dr. Sarkar, for that wonderful